All right, so we are right at 1 o'clock, so we are going to get started. Thank you all for joining us today. We're excited to have some really knowledgeable guests joining us to present on expanding access to healthcare through virtual and digital capabilities. And this is being presented by the Upper Midwest Telehealth Resource Center in partnership with the Ohio State Office of Rural Health. Okay, so quick disclaimer. All right, so just a quick explanation of who we are at the Upper Midwest Telehealth Resource Center. So we're a program of the Indiana Rural Health Association. We're a bit unique in that we do cover multiple states. This particular presentation is focused a bit more on Ohio, but we do cover the states of Indiana, Illinois, and Michigan. And then we're part of a larger nationwide consortium of telehealth resource centers. So essentially what we do is function as a telehealth clearinghouse. So we are first and foremost a TA provider. So if you've got a question about telehealth, we probably have an answer for you. And if we don't, one of our partner TRCs do. We also provide a lot of education and outreach like this webinar today, but also we have a YouTube channel where we have a lot of great videos, lots of educational videos. We also have a monthly blog that we post on our website, umtrc.org. We also have a podcast that I personally host called A Virtual View. So if you don't get enough of telehealth today, we've got a lot more for you. So without further ado, I am going to stop sharing my screen and turn it over to our first presenter here.
Hi, thank you so much, Danielle. Thank you for the invitation, and thank you everyone for joining. My name is Jessica Hoffler. I am with the American Telemedicine Association, and I am sharing my screen now. So happy to be here today to talk to you all about how to start thinking about expanding access to healthcare through virtual and digital capabilities, especially with the new rural health transformation programs that have begun. There are a lot of different ways to pull information together to build a strong, cohesive strategy. And that's really what inspired us to talk to you today. I am here with two experts. So I'm joined today by Jennifer Bay from the American College of Cardiology and Lauren Majors from Cincinnati Children's Hospital. And we're going to talk to you more about building data sources and putting them all together to build a cohesive strategy. So just briefly, a little bit about American Telemedicine Association. So we were founded in 1993, and our goal is to enable broader access to virtual and digital care in order to provide more people with access to high quality healthcare all around the country. So that's really bottom line our goals here. And now I'm going to turn it over to Lauren to introduce herself.
Hi, everyone. Thank you so much for the opportunity to come and speak with you all today. My name is Lauren Majors. I'm one of the senior program managers here at Cincinnati Children's Hospital. I work within the Center for Telehealth, which actually falls under our digital care pillar, and manage several digital health programs. One of them is remote patient monitoring. I also manage online second opinion and some inpatient telehealth. Our organization, we have a pretty broad reach within the digital care space. We have several Project Echoes that are live. We do virtual urgent care using video visits and remote exams. We also offer e-visits. We have school specialty clinics and school-based telehealth. And then we also have e-consults in addition to online second opinions and case conferences. So excited to talk about our approach and strategy and think about new and inventive ways that we can continue to expand care and reach families all across our UMTRC reach.
Great. And Jen.
Hi, everybody. Good afternoon, where you are. I am Jennifer Bay. I'm the Executive Director of Global Innovation here at the American College of Cardiology. I am based in Washington, D.C. now, but I am a proud Midwesterner and Michigander by birth. And so really pleased to be with you all today talking about this corner of the world, which is near and dear to me personally. A little bit about the American College of Cardiology. We are the world's largest cardiovascular medical professional society. So we have members all across the US and all across the world. And our mission is about transforming cardiovascular care and improving heart health for all. So today I will go into a little bit more detail about how we think about that in terms of assessing opportunities for improvement communities that we might want to focus in on, whose risk factors are a little bit higher than others. And I can allude to some of the things that the ACC does in engaging with technology organizations like the ATA and others to help close those access gaps.
Thanks, Jen. I just want to add before we really start to dive in that we would really like to make this a dialogue with you all. So please chime in with your questions or comments along the way. We are going to talk about some specific examples, but we would love your thought leadership in here as well. So I'm going to start by talking a little bit about digital infrastructure. So at ATA, I shared that our mission is really to support the adoption of virtual care and digital health to optimize healthcare for individuals. But we recognize that there are a number of barriers to adopting virtual and digital care. So back in about 5 or 6 years ago, we had an advisory group that started to talk and discuss about how to break down barriers to accessing healthcare, specifically using technology. And while we recognize that there are some huge barriers that people need to overcome, like culture and trust with the healthcare system and their providers, and digital literacy, health literacy in general, affordability and reimbursement policies. One thing that was at the tippy top of that framework was connectivity. And we really need to have connectivity in order for people to optimize the use of technology as more and more health systems use technology to reach patients where they are. So that's really where this idea of breaking down barriers to connectivity came to be. And as we started to dig into what really is connectivity, the committee decided that it was digital infrastructure. We knew that there is more to digital infrastructure than just whether or not there is broadband access. We thought that wasn't enough. And we know that there are maps out there that address that. But in addition to whether or not there is broadband connectivity, we also recognize that you need a certain level of internet speed in order to be on a virtual care call or even to utilize remote patient monitoring services. If it's a synchronous, it may need a synchronous connection. We also recognize that not every household has a smartphone or a device in it where you can utilize virtual care, digital care solutions. And we also recognize that in some parts of the country, internet services are very expensive compared to other areas, and that may be a barrier to adopting the right type of connectivity in order to utilize digital and virtual care. So we developed the digital infrastructure score using all 4 of those inputs to really be able to look at the real life experience of individuals, patients and their families primarily, on how they would be connected to the internet and therefore connected to their provider services. As we built this, it took several years to really come up with the right methodology. And I'll share a link to the methodology as well. You can share it with your statisticians. It's quite dense. But we thought that not all four of those inputs were equal. So they decided on a weighted band for all four of those inputs to create the digital infrastructure score. Danielle, were you able to share the link with the group that I sent? I just want people to be able to have access to it. The tool is free, so feel free to use it as we go along. So I'm going to do a really, really quick demo here. I'm going to stop sharing.
Jessica, I'm going to share the link in the chat so they can follow along while you present the material.
Perfect. Thank you. I'm going to share this screen instead. So the digital infrastructure score really drills down to the zip code level, where you can see, where you can visually be able to compare areas with a stronger digital infrastructure score that are in the dark purple areas, and the weaker score is in the lighter purple areas. So as we look into Ohio, you can visually see the differences in digital infrastructure scores. And we'll talk considerably more about this, but I just wanted to be able to show you, maybe let's look at Brown County here. You can start to see the different zip codes within Brown County, and we can start to look at this area. The red just means what I clicked on. It doesn't mean bad. But you can see that the availability is 53.57% of households there have availability to, and the average cost in that zip code is $44.99. The speed is 37 megabytes per second for download speed, so that's pretty low. And only about 72% of households have a device access. You can dive into these figures in the service area section too, to really figure out what is bringing that score down or bringing that score up. So you can utilize this tool for, as you can see, all of the different counties in Ohio to make comparisons, or even across the country. But hopefully you have that link now, and we can dive into it further as we keep moving along. The methodology is in there. There's the three little hamburger menu icons. There's a methodology information sheet there. So we are really proud to create this so that different types of organizations can work together around a data set to start to align on strategy. So you can see we have a number of different types of partners who could be using this tool, starting with provider systems and health insurance plans. They can identify areas where patients are struggling to receive access to care, and then identify what patient populations would be good candidates for virtual care solutions today, and what what populations may need more assistance, or dive deeper into understanding their barriers. And then we work with state, county, city, and other municipal departments of health to look at where populations are at risk of losing healthcare access and where virtual care would be of value today, and what areas need more investment in order to be able to access care more broadly. This tool is also great for research, as we'll expand upon today, being able to overlay various health data on top of the DIS. And of course, it's good for internet service providers as a landscape analysis. It also really highlights where competition amongst internet service providers would bring better value to individuals and their families through cost reduction and better internet speed. Lauren, would you mind talking a little bit about how Cincinnati Children's builds a strategy around internet and connectivity and digital infrastructure?
Yeah, I'd be happy to. It's hard to believe that I've been in digital health for over a decade, but I can think back to the early days around the conversation, and we were just excited to think about launching virtual visits. And we've come a long way since the earlier days when it was just thinking about one individual modality and how do we get that launched, and how do we think about the infrastructure to make sure that we can provide those different modalities of care, thinking about provider licensure, creating systems within our organization to expand and to scale. And I think the evolution along the way has been, as we've encountered different challenges, one, making sure that whatever modality or whatever digital health tool we launch, it's not creating a new or unintentional barriers that would prevent access to care with us trying to increase access to care. And so it's led us to be more strategic in our thinking and our planning around how we approach digital care in general. I think one way to look at this is how to overlay population health management and thinking about the different tools that we have available to us to really understand what patient population we really want to drill and hone into in order to serve. For some organizations, that could be your primary and secondary service area. For other organizations, it could be a larger geographic reach. It could be related to a particular diagnosis or an age group. There's all different ways to sort of, for lack of a better term, slice and dice how you want to identify who your patient population is going to be for the type of program that you're launching. The next thing, to do is to, and we'll talk about this, is to really think about the risk of those patient populations. What are the types of things that they're struggling with that you're, from a clinical perspective, going to need to treat and to provide care plans for? So when you think about expanding, technology or digital health to those groups, in the same way we do population health management, I think what Jessica is trying to communicate, we need additional tools to help us to identify the risks and the barriers that those populations could encounter when we're trying to reach out to them with the different tools available. So, for instance, if we were to drill down into Ohio, we could use the digital infrastructure score, like Jessica said, to look at connectivity or to look at different internet providers. That's one of the metrics. Is there 7 internet providers? Are there 12 internet providers? That starts to help us think about, what is the infrastructure in this larger geographic area? But then if you continue to drill down into county level or by zip code, when you start to think about the population health and you start to think about, the different layers of access they have on the technology side, then you can really get strategic on the type of digital tool that would be right for that patient population. So I mentioned at the start, we have video visits, we have e-consults, we have remote exam devices, we have remote patient monitoring. If we understand the complexity and the nuances of that patient population, now we can start to match the right digital tool for what it is that we're trying to do when we expand access to care. And it might mean that we don't just select one tool. Maybe it's multimodal, however you say that word. We use multiple modalities to reach that patient population. So for instance, in remote patient monitoring, our current program, we have 27 programs across 14 different divisions, and we monitor over 800 patients a month. And we have a really wide reach in Ohio. So it's not just our primary and secondary service area, it really spans the geography. So when we kind of look at that digital infrastructure score, we can see, okay, maybe some populations, they have really great access to broadband, but the connectivity is really low in terms of the speed. So we can start to anticipate, okay, what are we going to do when our video visit, fails? What's the backup? Do we have access to messaging patients securely? Are we going to rely on phone calls? So we can start to get much more strategic in how we roll out a program and ensure that we're not creating additional barriers when we're trying to remove other barriers. So I'll stop there because I could talk about this all day and we'll get into some other maps, but that's generally how our evolution has occurred. It's really trying to get much more strategic and overlay different types of maps so that we can get more targeted in our approach.
Thank you so much for mentioning, the concept of not trying to make more barriers, because I think that is a worry amongst, especially those of us working in health technology, is we don't want to make this worse. We don't want to make access harder in different ways. So that's another reason that we use this tool, is really to understand the readiness for a community to be able to adopt virtual care and digital health. So I'm so glad that you mentioned that. In this next slide, we're really starting to set the stage for our primary discussion on how to layer in data and how it helps. So this many of you are likely familiar with. It is from the Ohio Department of Health, and it highlights the different rural counties out in Ohio, identifying them as rural, partially rural, urban, there's Appalachian, and then it starts to source out where there are rural health clinics, critical access hospitals, and FQHCs already in place. I think that's really important and a really helpful map to show what resources are already available in communities throughout the state. But it's limited on information, right? So you can understand if there's a rural area or partially rural area, but what does that mean? You need more data to go along with it. And that's really where we start to add on digital infrastructure on top of that. So is it a rural area? And does that mean that they have poor access to connectivity? And if so, why? Is it because there are fewer devices in a household? Or is it because the actual internet speed is low? Or is it that it's very expensive, so less people have it? We can really start to suss out what are the exact challenges in those areas that we're targeting. And then as we start to build upon what our goals are. So, in talking with Lauren and her team, they work with children, Children's Hospital. So we started to think about what is really important. What are some common challenges that Cincinnati Children's faces and they're trying to address? So we started looking at maternity care access, and we found this map from the March of Dimes in their 2023 Maternity Care Deserts report for Ohio. And we started to see where there are maternity care deserts, low access, moderate access, and full access to maternity care. And then we're going to start to dive into more health outcomes data with Jennifer's data sources. And she is going to introduce this really important heat map as well.
Hi, everyone. Thank you for giving me a few minutes to tell you a little bit about the health equity heat map. I'm hoping that our hosts can take the link from the panel side and put it into the group chat about the ACC tool so that everyone can have access there. But the essential thing that we seek to do in this heat map is to understand really what's happening in communities and how that impacts both cardiovascular risk and the presence of cardiovascular disease. So if we could go to the next slide. The data is ultimately feeding off of two things. And so you can drill down if you decide to play with this. I am not going to demo here, but to drill down to a community, not just by county, but by census tract level. So you can get pretty granular data from the perspective of if you were representing a healthcare system and you were trying to understand the communities that are in your catchment area, what's happening. And we're finding, as you'll see further into our discussion today, that different communities at that really more nuanced level really do have different experiences. But a little bit here on the social conditions and cardiovascular outcomes that we're breaking apart with this map. The notion is that overall vulnerability is related to the things that are commonly associated with lower healthcare outcomes. So lower income or poverty, any issues with the percentage of your budget that you pay for housing, education, the very old and the very young, single parent households, and also some things that are going to be really important later here as we think about reach and sort of one step ahead of the discussion that we've had so far together today about targeting digital health programming for certain communities is where are those communities that are particularly in need of these kinds of interventions, perhaps. And so we'll look at some data kind of across these different tools to really understand that a little bit later. But as I show you a few visuals in the upcoming slides, it's really these purple areas here at the very top. This gradient represents, thank you, Jessica, represents both, the risk of cardiovascular disease or coronary heart disease, and also risks based on this overall vulnerability is broken out here. And so we'll start to look at some pictures here in the subsequent slides to see how that plays out. Just a quick note here on the heat map resources. So this is all CDC public data that folks could access, but it is largely a few things beyond the fact that this is census tract and not county data. And so that some of our maps might look a little bit different than some of the county level reporting that you might see. But also that the health data in particular is self-reported. And so that's really important to note. We can go on to the next slide. So here's a heat map of Ohio itself. And, I think what we're seeing here, and because we're focused on rural populations, I want to actually draw attention to the communities that are in the spaces in between all of your urban centers. And what we see, if we particularly look towards the bottom of the map, Southern Ohio, we see several areas that are, in that purple category of, again, certain community impacts, whether it's income and transportation and all those things that create vulnerabilities, and then also prevalence of cardiovascular disease. And to make the clinical link back to what we were talking about with maternal and child health, there is a bit of a daisy chain relationship in that the presence of risk factors for cardiometabolic disease, so heart disease, diabetes, are highly correlated then with poor maternal health and then, infant health beyond that. And so these really are sort of a continuation clinically of risk factors that could be viewed together as we think about, as Lauren rightly noted, public population health and public health interventions in those communities. Could we go to the next slide, Jessica? So I wanted to zoom in here a little bit, and this is a bit more back to Lauren, to talk a bit about, Cincinnati Children's being sort of in the county seat down here, if you will, or in this area. What we wanted to do was pan out with our tool. And again, this is something that any of you could do in any part of the states represented here, is to pick your area and then zoom in and zoom out. But you can see these oddly shaped regions. These are these census tracts, and we've highlighted one in Brown County in yellow here to just give a little bit of a sense of what we're talking about when we're talking about these areas that are rural or semi-rural and their ability to get to, care and the risk factors that we might want to be thinking about when we're thinking about those patients as they present in our facilities. So in this instance, in this particular census tract that is in Brown County, we're noting that it's about a 60-minute drive from Cincinnati, and it's reflecting a few really important things that I wanted to highlight for the group today. So the first is that if we look at the top for the socioeconomic vulnerability here, what we're seeing is in this picture of this community is that that's telling us, that higher number is telling us that we might be dealing with questions about insurance coverage or affordability of care and ability to pay. Under housing and transportation, that's that aggregate again of where do people live? Do they have consistent housing, but also access to a vehicle? And when we think about transportation limitations, it makes the importance of digital interventions for continuity all that more important for populations that might not have easy access to transit into major cities to get their care in person. And so how do we maintain that reach? And then again, in this particular county, if we go down to the risk factors at the bottom and we're looking at the risk factors for cardiometabolic disease, what we're seeing again is, a little bit of a spike here in terms of those risk factors for obesity, high blood pressure, high cholesterol, and diabetes. And so, sitting from the perspective of clinicians focusing on community health for this particular population, you might want to then look at the digital interventions that might help us to reach these folks a little bit better so that their outcomes improve. And we can go to the next slide, I think. Back over to you.
Yeah, so this next slide is, builds upon what we've been talking about in terms of understanding what type of setting individuals and families live in, whether it's rural or urban, and then what their digital infrastructure looks like. Then building upon that, we have understanding their access to maternal care, and then their cardiovascular and social risks. And now we're building upon that and looking at infant mortality averages. And so this was by the Ohio Institute for Equity and Birth Outcomes. And we wanted to look at what areas have higher occurrences of infant mortality. And it's really interesting to see the differences here when we compare all of the different data sources along the way. But I wanted to share that. And then, Lauren, I'm hoping that you can share, I think you've touched on it a little bit, but can you talk a little bit more about your health system's reach in terms of, being primarily, you're headquartered in Cincinnati, but where you extend care services to?
Yeah, I'd be happy to. So if you look at the top right map, you can see where Cincinnati is located. We really sit in this tri-state area. And when you think about reach in terms of care, there's sort of like this inbound and outbound reach. As many of us know in digital care, I mean, geographies and boundary lines still exist and they're still important. However, when you talk about virtual urgent care or video visits, some of those boundary lines are lifted. So, for instance, if we have inbound, I can think of an example going back to the Brown County kind of circumference, where we may have patients that reach out to us. Maybe it's through a virtual urgent care visit. Maybe it's through a connection through a school-based telehealth program. Sometimes they'll go to their primary care provider, and that primary care provider will want to ask a specialty specific question. And so they'll reach out through our system and they'll have an e-consult. Or maybe a family wants a second opinion and they'll reach out through online second opinion. So if you talk about it in terms of like digital front doors, there's lots of digital front doors and ways that families can reach out to us without leaving their home. Then we have other scenarios where maybe the patient is originating, they have an inpatient stay for a particular condition. Maybe it's an infant and they've had a NICU stay. And we think about, the geography, how can we continue to engage them between visits? So this is where things like remote patient monitoring comes into play, or e-visits come into play. And I think it's important to think about those risk maps because on the previous slide, when you were looking at connecting, how do you connect maternal health and infant health together and help create a through line. One example could be prenatal hypertension. We want to make sure that we don't have babies that are being born early due to preeclampsia. So can we deploy remote patient monitoring programs? We have a fetal care center. Not everybody comes through our fetal care center, but just as an example, can we deploy remote patient monitoring programs for those high-risk pregnancies and monitor blood pressures? If an infant, even if they come in and they have a NICU stay with us, how can we continue to monitor that baby in maybe our poor weight gain program, or we have a NICU follow-up clinic program where we're just monitoring weight and growth so that those families can stay connected. We have in our RPM program, we have a centralized remote monitoring team of about 13 nurses now. And our response rate, so when a family actually sends a message in, we have an application that we give to everybody who's enrolled in this program. When they send a response in, that we have a 2-minute turnaround time for an actual nurse that's interacting and engaging with that family. We send devices home with the families. So there are ways to expand this reach and to think about population health and to think about transportation issues. And when we're designing RPM, as just the last example, so that I don't want to be too long-winded, there are some populations where maybe they don't use technology. Maybe it's a cultural or religious thing. We can pivot, and there's lots of different ways to still do RPM using maybe it's an actual telephone call. Maybe they're fine with telephone calls, but they're not okay with using an iPad, for a video visit. So there's different ways when you're talking about what modality is right for the patient populations that you're serving. And I don't want to forget too, because we have a large focus on making sure that it's not just only looking at one of those social drivers of health, but that it's broad. Think about language access too. And sometimes when you're just solving for language access within technology, sometimes you discover more quickly what barriers you might have because you have to be able to serve multiple patient populations with language. So again, those are some of the ways that we look at different maps. We look at risk scores. And the last thing I'll say, so I have a background, I'm a lactation consultant as well, and how we've used, looking at infant risk is in population health. So, what do our babies actually have food insecurity? And food insecurity, sometimes that's formula. So that's one of the questions that we ask in RPM. Are you at risk of running out of formula? If they are, we help facilitate that with our families. Do we provide, lactation support? Can we do that through telehealth? Are we helping to ensure that those babies are getting, access to food, so that it doesn't have a trickle down effect when we talk about poor weight gain and poor outcomes within our patient population? So there's lots of different ways that you can design and structure a program and kind of overlay the tools and the resources available. But I think it's helpful to start thinking very strategically, so that you can really drill down and serve your patient populations in the most effective way possible with a myriad of different tools available.
Thanks, Lauren. We just have one more slide to go over, and it's really just double clicking on these maps combined into the figures. So I'd love to start to open it up to the audience to see if this is resonating with you as you're starting to think about deploying programs throughout Ohio, beyond the use case that we're presenting here today. But it would be wonderful to hear any questions or any comments about what you're doing today or how you're using data to inform your strategies. But let's dive into some of these numbers. So again, this is just double clicking into comparing the maps that we had previously. And I know we wanted to highlight Hamilton County, even though that's where Cincinnati is. We know that that's not rural, but we wanted to show that just because it's in an urban setting and it has full access to maternity care doesn't necessarily mean that they have positive health outcomes always. You can see that they still have a high rate of infant mortality, unfortunately. And so we can start to build a strategy around how do we reach these patients that really, really need an intervention? Does it have to be in person? Can we start to deploy some telehealth services or remote monitoring programs for them too? But we mentioned Brown County, so let's look into there even more. So it's a partially rural area with a digital infrastructure score that ranges from 38 to 57. That's not great. We know that Brown County's digital infrastructure score shows that it's expensive. The internet service is expensive, and the actual speed is low. So they may not be a good candidate for virtual care video services. That may be more telephone or text even. It also is an area that has a lower device access score. So to Lauren's strategy previously that she shared, Some of those patients may need to take a device home with them if they're deploying that sort of strategy. Do you want to comment a little bit on the prevalence of CHD, Jen, in that area?
Yeah, yeah, absolutely. Um, so in this instance, what we did was, and I want to make sure I call this out. So for Brown County, we were focused on a census tract when we zoomed in on the map, and that had a different prevalence of CHD. And so you could really see even in a subset of the county that there was higher prevalence in that one census tract. But across the county, our prevalence is at about 9% of the population, and that's an aggregate again, of those different cardiovascular diseases, but they include things and linking back to maternal health, hypertension. And we know that hypertension elevates the risk of preeclampsia, which elevates the risk of, early term birth and then poor outcomes for babies. And so these kinds of things can easily be stitched together. The social vulnerability index is again just another way of looking at that data to let us know, are there any other barriers that we need to be cognizant of as we're thinking about broadband access and, sort of those sort of tools that we might want to deploy in communities in terms of both, do they have the Wi-Fi ability and do they have the ability to pay for Wi-Fi in some of these areas too, which can also sometimes be a challenge.
So when we start to put all of this together and we think about how do we address some of these health challenges and access challenges, who are all of the parties that need to be at the table to bring this all together? And Lauren, I'd look at you, but I would even start to think about like what do departments of rural health need to think about? Who do they need to bring in? Um, who are all the parties that need to sit down and come up with some strategies?
I think some of it's going to be dependent on the area that you have, that you're planning to reach out to. Community partnerships are so important. This could be community hospitals, this could be departments of health, this could be FQHCs. We think about maternal health, this could be WIC clinics. WIC clinics are really important. So community partners are key. And I think doing an analysis of, what does everybody bring to the table? So what's the problem that we're trying to solve? Who's our patient population? What does everybody have that they could, if we were to, pool our resources? And then how can we create really strategic, handoff points of communication so that we're decreasing gaps in care when we're moving from either institution to institution or urban to rural or whatever that change of locale is, whether it's in person or from a digital viewpoint. So doing a really, just like you do an assessment to identify who your patient population is, the problem or the condition, and then what's the right tool for that. I think in the same way, kind of looking at the area and what exists current state and think about your future state and then try to do that gap analysis and figure out who needs to come to the table so that you have all of your key stakeholders represented.
Yeah. And Jen, I've had the luxury of hearing you talk about the importance and impacts of community investments before. Can you share with the group what your experience is when you compare areas that have had investments and those that have not?
Absolutely. So, when we zoom around and would strongly encourage folks to take a peek at the tool itself, we have a proxy measure for community investment baked into our tool as well, which is the legacy of redlining policies, which were effectively a way of thinking about investment versus not in communities. And in communities that, lacked that investment, what we're seeing is generational changes in terms of the cardiovascular outcomes in those communities. And I see that as, going back to, again, if we're realizing that infrastructure investment can positively impact health, then we have this opportunity now with the advent of broadband-based technologies to expand our reach to populations who we know might have trouble getting to us as clinicians if I'm sitting there in a hospital. That, investments in that kind of infrastructure can help us do the important things that Lauren and her team do when they're trying to make sure that folks have access to consistent care and that we're supporting the outcomes that we all want to see happen in our communities. I am seeing as well some Q&A here. Jessica, I don't know if you were seeing that as well.
Yes. I'm going to there's one for the digital infrastructure score. I'll do that one first because I have a quick answer. The question is, how is affordability calculated for each county in the DIS? It's actually calculated at the zip code level, and then it's sort of aggregated up to the county and then the state. And it's calculated based on the cost per internet per household income. So I am going to share the link to that methodology document, but that is essentially how it goes. And then there was another question for Jennifer about this person says they're fascinated that only about 1% of total cardiomyopathy patients have been genetically tested. So starting to use claims data to back into counties and providers who are and are not genetically testing. Do you have any more insights on how genetic testing data is being used for improving cardiovascular care?
This is a very short answer because I am not a clinician and I'll own that from the jump. But I will say here at the college that we are focused a lot more on genetic risk factors as we're starting to understand them better. So things like cardiomyopathy that runs in families. My goodness, now I'm tripping over my words today. And hypocholesterolemia as being two important risk factors. So there's more science that is coming, and the college is updating its guidelines for that. And to, bring that back to the topic here about, fundamentally what we're trying to do is understand risks in groups of people and bring the right interventions to those groups of people so that we can get the health outcomes that we hope that we can all achieve. And I think that genetic risk is just one part of that, sort of one lane over from what we've been talking about already today, just in terms of like infrastructure available in communities and those kinds of things. So I appreciate the question.
Thank you. Hopefully Danielle can help me put the link to the digital infrastructure score methodology into the chat. But I think we're running out of time, so I would love to have some parting words from Lauren and then from Jennifer. What would you like the audience to take away from this conversation? Sorry, Lauren, I put you on the spot.
No, that's okay. I thought you went to Jennifer. I think one of the key takeaways is digital health is transforming rapidly. And, when you think about even the introduction of AI, we didn't even talk about AI. It's going to continue to evolve. And the ways in which we can approach and strategically think about how to approach serving patient populations and getting care to places where it's been challenging in the past, I think our strategy around that needs to evolve as well. So that would be my key takeaway is, think about overlaying population health data with the tools and the resources that we have available. And I would also say, if you're thinking about how to do this more strategically and you're running into issues, I don't have enough data for the types of things that I want to do. I think this is where I'm sure I don't want to speak on behalf of the ATA, but I think giving that information back so that even this digital infrastructure tool, things like this can continue to evolve so that we have the right information. I think us as who's doing, clinical care as a stakeholder in general, sometimes we have key insights into that, but we don't always share it. And so having a voice, communicating that, and then collectively working together. I see a comment in here around the VA. I think that's a great idea in terms of leveraging the VA, and that goes back to who are your key stakeholders, who do we partner with, what your resources and tools can we collectively pull together to kind of have a different hat on and have a different take for how we can approach expanding our methodologies.
Thanks, Lauren. Jen?
Lauren said all the great words. So I think what I'll just say as a closing thought is, I think that the more we can bring data together to really understand communities of people and the challenges that might exist in accessing consistent care for, chronic conditions, whether they're heart disease or anything else, the better outcomes that we have. And there was also a question in the chat about, and so I'll answer it a little bit with my closing comments and maybe turn to you, Jessica, but it's about why is DIS important when we can directly assess social determinants of health of an individual patient? And I appreciate the question that, obviously each individual person is unique and represents their, unique risks. And I do think that that's important in a one-on-one relationship between a clinician and the individual patient. They are serving one at a time. At the same time, many of us run programs where we're directing resources to communities. And so understanding things at a broader level, whether it's at a county or a census tract or statewide, would help us to perhaps more efficiently allocate those resources to, better move the dial on health outcomes across people as groups defined by their geography. And so that would be my answer to why the DIS question might be important. Also, for things like local advocacy. I mean, you think about different municipalities and how they invest in infrastructure and communities. Perhaps we would want to call attention to places that aren't caught up with everyone else, and we can reveal that certainly through the ATA tool, and then make links to health outcomes through the ACC's tool. And so to really understand that this is about more than just who has access to internet easily and who doesn't, but it's also about the impacts that can have when we have solutions that are readily available through digital health to get people's outcomes where we want them to be.
Yeah, thank you. That was very, very much aligned with what I was going to say, which is really the whole idea of this webinar is pooling data sources together to understand the links between community investments and connectivity all the way through health outcomes, and really bringing together different groups, different parties, state agencies, health systems, health plans, internet service providers, nonprofit community organizations, local clinics, being able to bring all of these different parties together to identify what areas need more investment in order to improve specific outcomes for specific populations. And so it's not as dense as the micro individual level, and it's not so high and macro in the state level. It's kind of some more targeted in between to really talk about community investments and how to bring those to the right populations at the right time. I hope that this was helpful for everybody. Please reach out if you have any questions to any of us. it's really a great opportunity to share these resources and experiences with you all. And Danielle, thank you for having us.
Thank you so much.
Thank you,
course.
everyone.
Thank you so much for joining us. We really appreciate it. We'll be sending out these slides, but in the meantime, if you could fill out our feedback survey, let us know how we did. And also join us on our next webinar on March 3rd at 1 p.m. Beyond that, thank you all so much. Thank you to our guest speakers here. I'm going to close the webinar, but if you have additional questions that you didn't get a chance to ask, please do feel free to reach out to us at info@umtrc.org and ask us, and we can get you connected. Thank you all so much.
Thank you all so much. What a fantastic presentation. And we will share contact information of all our speakers. So if you have additional questions, you can reach out. Thank you. Bye, ladies.
Thanks,
Bye-bye.
everyone. Bye-bye.